The objective of this video is to describe the feasibility and technique of endovascular stent grafting for leaking ascending aortic pseudoaneurysm. We have no relevant disclosures. This is a 59-year-old male who was transferred to our hospital from an outside facility with 1 week symptoms of progressively worsening shortness of breath, non-productive cough, mild substernal chest pain, and palpitations after a recent cardiac surgery. He was in NYHA functional class 4. 6 months ago, he underwent coronary artery bypass grafting and ascending aortic replacement. His surgery was complicated by pericardial tamponade, requiring an emergent pericardial window and superficial sternal wound infection. 3 months post-op, he required cholecystectomy for acute cholecystitis, and 5 months after his CABG, he underwent catheter ablation for persistent atrial fibrillation. His past medical history was significant for chronic hepatitis C with evidence of mild liver dysfunction and chronic renal insufficiency. He was still in persistent atrial fibrillation and anticoagulated. His other comorbidities are listed. His cardiac cath was performed at the outside hospital, which revealed patent Lima to LED graft. Both of his cephalous vein grafts were occluded. His preoperative transthoracic echocardiogram revealed normal LV function and ejection fraction of 55%. He had no significant valvular abnormalities. As shown in this volume-rendered 3D image, he was noted to have contrast-filled cavity originating from supracoronary ascending aortic graft, which was surrounded by 10 into 10 cm thrombosed pseudoaneurysm extending from aortic root to the proximal arch. The coronary arteries originated just below the thrombosed pseudoaneurysm. His Lima to LED graft was also noted to be abutting the pseudoaneurysm. He had mild compression of SVC and main pulmonary artery, as well as subtotal occlusion of right pulmonary artery. The most likely source of pseudoaneurysm seemed to be a pinhole entry in the distal ascending graft, possibly related to the site of previous bypass graft, as shown by the proximal anastomosis marker with the blue arrow. His surgical challenges included emergent reoperative sternotomy with patent Lima to LED graft and history of previous sternal wound infection. Furthermore, because of his comorbidities, he was felt to be very high risk for redo sternotomy at this point. Based on feasible anatomy of pseudoaneurysm, surgical acuity, and our experience, he was deemed to be a good candidate for endovascular repair of his ascending pseudoaneurysm as a bridge to survival in the acute phase, with the possibility of requiring an open surgical repair later on. Preoperative planning included a detailed imaging analysis using 3D imaging software. Aortic measurements were obtained at multiple landmarks: proximal ascending aortic supracoronary graft, distal ascending graft near the distal anastomosis, and proximal aortic arch. Length measurements were also taken from the highest coronary to the origin of brachiocephalic artery along 3 paths, including greater curvature of the aorta, center line of flow, and the lesser curvature. The CT scan measurements were subsequently confirmed by IVUS. The patient was brought to the operating room, and following the induction of general anesthesia and placement of necessary monitoring lines, he was prepped and draped in surgical sterile fashion. Surgical exposure of left common femoral artery was obtained. Left common vein was also exposed. Wire access was obtained to femoral artery, and wire was delivered into ascending aorta across the aortic valve. Exchange was made for the Landquist wire. Percutaneous access to the right brachial artery was obtained using ultrasound guidance. This was upsized to a 5 French sheath, and a pigtail angiographic catheter was then placed in the aortic root. A 5 French sheath was also placed in the left common femoral vein, and a transvenous pacemaker was placed into the apex of right ventricle. IVUS and the TE were used in addition to the fluoroscopic guidance. We performed an aortogram which confirmed the flow into the aneurysm sac from distal ascending aorta and the location of coronary arteries, as shown in these images. We used the IVUS to assess the aorta, confirm our measurements, and to ascertain the location of highest coronary vessel. The measurement of previous aortic graft and the size of aorta just beyond the old graft anastomosis were assessed as shown in the images using IVUS. This confirmed what we saw on the CAT scan. Stent graft was delivered from the left common femoral artery and positioned into the ascending aorta. Once the device was in place, we used angiography to confirm the positioning. Hemodynamic displacement forces were reduced by rapid ventricular pacing during the device deployment. A 34 into 77 mm stent graft was successfully deployed. A 34 into 77 mm stent graft was successfully deployed using rapid pacing without any difficulty. Next, the exchange was made for a 40 mm coda balloon. The device was ballooned across the distal anastomosis. Completion aortogram showed excellent positioning of the device just above the origin of the coronary arteries and confirmed the brachiocephalic and coronary vessel patency. There was no flow in the pseudoaneurysm and any endoleak. Completion IVUS showed an excellent seal of the device against the wall of old graft and patent and unobstructed brachiocephalic vessels. Postoperative TEE also confirmed the patent coronary arteries with excellent flow in the proximal coronary vessels. The patient was awakened and neurologically intact. He was taken to the ICU intubated in a stable condition. He was extubated on the day of surgery and transferred to the step-down unit on postoperative day 1. IV anticoagulation was started for near complete occlusion of the right pulmonary artery. Postoperative volume rendered 3D images revealed a well-positioned stent graft in the ascending aorta. Postoperative standard axial cuts showed complete obliteration of the leaking aneurysm and no endoleak. Patient also experienced symptoms of shortness of breath and dyspnea on exertion in the postoperative period. He was noted to have a large right pleural effusion. A right thoracentesis was performed on postoperative day 3 and 2200 ml of straw-colored pleural effusion was drained. His symptoms and exercise performance significantly improved afterwards. He was transitioned to oral anticoagulation and discharged home on postoperative day 6 after achieving the therapeutic INR level. We conclude that ascending aortic stent grafting is a feasible alternate in high-risk surgical patients with secular and focal aneurysm and a suitable anatomy. It should be considered a complementary to the open repair. This can also obviate the need of preoperative sternotomy and can be used as a bridge to the definitive treatment in acutely symptomatic high-risk patients. Thank you very much for your attention.